Good afternoon. My name is Alan Pierce. I'm a founding board member of the John P. Mayhew Foundation, and it is my distinct honor to introduce our next guest, Dr. Richard McKeon. Dr. McKeon is Chief of the Suicide Prevention Branch Center for Mental Health Services of the Substance Abuse and Mental Health Services, more succinctly known as SAMHSA. He oversees all suicide prevention activities, including the Smith State Tribal Youth Suicide Prevention and Campus Suicide Prevention Resource Center, and the Native Aspirations Program. In 2008, he was appointed by the Secretary of Veterans Affairs to the Secretary's Blue Ribbon Work Group on Suicide Prevention. In 2009, he was appointed by the Secretary of Defense to the DoD Task Force on Suicide Prevention in the military, among many other positions he has held. He is also the co-chair of the Federal Working Group on Suicide Prevention. Please welcome Dr. McKeon.
Well, it's a pleasure to be with you here today, and what I'm going to try to do is to give you an overview around the challenge of suicide and the promise for suicide prevention in the United States, with a special focus on our military and on our veterans. As was mentioned in the kind introduction, my role is as Chief of the Suicide Prevention Branch at the Substance Abuse and Mental Health Services Administration. And this is certainly a critical time for our federal efforts as well as efforts in states and communities. So let me go over a few things that I think is important for you to know. One is that it's important for you to be aware of the extent of the challenge of death by suicide in the United States. Okay. In 2017, the last year for which we have data, over 47,000 Americans died by suicide, making it the 10th leading cause of death in the United States, second leading cause of death from ages 10 to 39. Okay. In addition, it is one of the few leading causes of death that has been increasing, while many others, the trajectory over the long term has been down for diseases such as cancer and heart disease, stroke, etc. In fact, in a combination of the people that we've lost through the opioid crisis and other fatal drug accidental overdoses, as well as suicide, life expectancy in the United States has declined for the last 3 years. For the first time since the Great Flu epidemic approximately a century ago, the Princeton economists Case and Deaton have referred to these as the deaths of despair, and that it is that despair which unites the deaths by suicide as well as accidental overdoses. And sometimes it may be difficult to determine, in fact, whether a death was accidental or a suicide death, and therefore may be undercounted. We also know that there are many, many Americans who think about suicide or make non-fatal suicide attempts. SAMHSA has data on adults over the age of 18, and in the 2017 data indicate that over 9 million Americans seriously considered suicide in that year, and about 1.3 or 1.4 million made a suicide attempt, and that's only the adults age 18 and above, okay? And between 2016 and 2017, the increase of about 3.8% in deaths by suicide was the largest increase in a decade. So there is a lot of work that needs to be done in order to stop these increases. In fact, deaths by suicide are roughly equivalent to accidental overdose deaths through the opioids. These are really the twin scourges currently for both 47,000 deaths. Overall overdose deaths from all substances are about 70,000. So there's a lot of very important work that needs to be done, and it's within this context that we need to view suicide among our nation's veterans. There is certainly a connection between suicide and mental health issues. Suicide is complex. It's usually multiple factors. So it's usually not only mental health issues, but often a mental health issue or condition combined with others. And as you can see here, over 46 million lived with any mental illness in 2017. We know that major depressive episodes have been increasing among our nation's youth, and that those with a serious mental illness have a rate of suicide 25 times greater than the general population. This shows you the steady increase that's taken place over the last 20 years in the United States. And you can see that that increases for both men and women. Many more men die by suicide than women, but it's been increasing among both. So in response to this, SAMHSA has a number of different programs that works to try to reduce suicide in the United States. We have the National Suicide Prevention Lifeline, which last year answered over 2.2 million calls. It's 1-800-273-TALK. In many places in the United States, if it's the middle of the night, or perhaps even if it's on a Sunday afternoon, if somebody is thinking about suicide, the only places they may be able to get help are in an emergency room or by calling the National Suicide Prevention Lifeline. And since 2007, there has been a feature on the Lifeline where if you press 1, you are connected to the Veterans Crisis Line. The Veterans Administration operates 3 large, highly effective crisis centers in Canandaigua, New York, Atlanta, Georgia, and Topeka, Kansas. In addition to the Lifeline, SAMHSA sponsors a national resource center called the Suicide Prevention Resource Center. Probably the single largest collection of resources on suicide can be found there. We have youth suicide prevention grant program called the Garrett Lee Smith Youth Suicide Prevention Grants. Our evaluation of studies have shown that counties implementing activities funded by this grant have lower rates of youth suicide than match counties who do not. So that's really important. The challenge is, however, that when the funding fades, the impact fades. Okay. So we know there's a lot more that we need to do to embed suicide prevention in states and communities, in organizations across the country in order for us to be effective. We know much more now about how to do effective suicide prevention than we did in the past. We have programs called the Zero Suicide Initiative, which is to strengthen suicide prevention in healthcare systems. Right? The VA has been a leader in doing suicide prevention within healthcare over the last more than a decade. But we're really working to try to make sure that the entire healthcare system is using the most up-to-date science and research to prevent suicide. Basic things like when somebody is being seen for healthcare, are they asked if they're having suicidal thoughts? If they're asked and they say yes, do we work with them on a safety plan, a cooperative plan to try to help keep them safe? Is there availability of evidence-based treatments? There are now multiple treatments with evidence and randomized controlled trials showing you can reduce suicide attempts. Do we pay attention to staying in contact with people during entire episodes of care? Because we know that when somebody leaves an inpatient unit or leaves an emergency room, they are still at high risk for suicide, and they need continued contact, but most of our healthcare systems are not set up to do that. You may be surprised to learn that many mental health professionals are not trained in suicide risk assessment, management, or treatment. Okay, you would think that that would be something that happens automatically. Unfortunately, it doesn't, although that is getting better. I mentioned the Lifeline before. I also want to mention that currently VA and SAMHSA are working closely on endeavors called the Mayor's Challenge and the Governor's Challenge to reduce suicide among veterans, service members, and their families. This is important because of the average 20 veterans a day who die by suicide, on average 20 veterans a day, only 6 are currently in VA care. The other 14 are not. That means we all need to work together as a nation in order to reach the entire community of veterans, because the VA is best able to reach the 6 who are already in their care. We need to work together to help reach those other veterans. So for this reason, we've worked together with VA to do what's called the Mayor's Challenge to reduce veteran suicide and the Governor's Challenge to reduce veteran suicide. I'll just make a couple of points and then I'll open it up for questions. But the important thing to know is that we are working with cities and states around the country in an effort to try to bring communities together in a comprehensive way to focus on reduction of suicide among our veterans. One thing that's important to be aware of, although there's a crucial role for mental health treatment, we're never going to get to where we want to go if we wait for people to come to the offices of psychologists like myself or a psychiatrist. We have to reach out. We have to make connections. We have to be working with communities in order for that to happen. One other thing that I will mention, and I'll mention in closing, let's see, those are the cities, those are the states. We're particularly trying to focus on not losing veterans who are in crisis, who are connecting to community crisis and emergency systems as opposed to VA systems. I'm not going to go into detail around that. These are, again, some of the places we're working with. One of the things that SAMHSA is trying to promote is to improve crisis services in the United States. This is a model that was published by the National Action Alliance for Suicide Prevention. It's called the Crisis Now model. The idea is that we would want to move toward every community in the United States having access to a crisis stabilization unit, to a mobile crisis team that can come to where they are, and a call center hub, using what we call the air traffic control model. So we all know that when we're taking an airplane, there's an air traffic controller who's responsible for tracking where that plane is. There should not be any time where there's not an air traffic controller who knows where the plane is. Well, that's the model we think should exist for crisis services and emergency services when somebody's at risk for suicide or for an accidental overdose. So in an era when we can track a package halfway around the world, it should be unacceptable for us to lose track of veterans and other Americans at risk for suicide between the cracks of our healthcare systems. So that's one of the areas that we are particularly trying to work on. And the other thing that we know is that intervention during this time saves lives. The science is sound. It's a question of helping work with our systems in order to accomplish this. In a study of almost 1 million veterans being treated for depression, the time they're at greatest risk for suicide was in the days following their discharge from an inpatient unit. So it's something we have to pay really close attention to. And you can say the technology exists to track packages halfway around the world. Technology also can exist and should exist to help in our crisis systems not lose track of people at risk and staying in contact with them throughout a period of crisis. And then finally, I'd like to let you know, in August, the Congress passed and the President signed into law the National Suicide Hotline Improvement Act, which calls on SAMHSA and the VA to make recommendations to the FCC about the potential benefits and challenges associated with assigning an N11 number as a national suicide number. Currently, that number is 1-800-273-TALK. The notion is that a three-digit number, such as 611, for example, would be more easy to remember and could lead more people to call. That report is actually public, the VA's report, as well as SAMHSA's report on the FCC website. And the FCC will be making its report to Congress this summer. I am going to stop with that, and I'll take time for maybe just a couple of questions, if there's anything anybody would like to ask. Yes, there are models for it. So for example, a good example would be Behavioral Health Link in Atlanta, Georgia, where they are able to track on whether somebody is waiting for a mobile crisis team to arrive after a crisis call, whether they've gotten to a hospital emergency room. And in Georgia is one of the few places I'm aware of, if somebody's seen in an emergency room for a mental health issue at 2 in the morning, they can not only be given a phone number to call, which is what's typical and which doesn't work very well, but they can actually be given an appointment in the community mental health system. So that's a real advance. They also are able to track on inpatient bed availability. So it's not perfect. It doesn't track on everything, but it's a very good start. In the Rocky Mountain Crisis Partners in Colorado is another system that's doing a piece of this. And the technologies certainly do exist. The full implementation into systems of care is what we're working on. Thanks for the question.
Okay, I have a question about why do you think the suicide rate has gone up?
Well, that's a great question, and I think the suicide prevention field, and I would include myself as part of that, has really not come up with a really adequate explanation of it. There are different theories about it. One in terms of youth, talks about social media, increased isolation among youth. We know that major depression, suicidal ideation, and suicide deaths among youth are going up. But also it's been going up among older adults as well. So it's clearly not only that. We know multiple things are coming together. Case and Deaton's work suggests that education is a major issue. In other words, when you look at those with less than a high school education versus those with a college education and above, there's a significant difference in suicide rates. So it's probably an interactive kind of pattern where, for example, and then some people talk about the economy, the great economic crash of 2008, but it's not only that. But it could be that, the kind of situation we know unemployment is associated with suicide, but unemployment's going down while suicide's going up. But it may be a combination of factor. If you're in a community and you lose your job and you're disabled and it's hard to get another job and you can't afford to move to an area that has more jobs because the housing prices are greater, et cetera, and you start to drink and become depressed, these things can all come together. But the science doesn't really, these are hypotheses about it. And I said, these are, what I just described to you is the hypothesis coming from Case and Deaton, the Princeton economists who have looked into this and written extensively about what they call the deaths of despair, which are suicide, the opioids, and alcohol-involved liver disease. But it is something we desperately need to understand better, so we can use it to help guide our suicide prevention efforts. Was there another question? Okay.